Hello, my name is Hyunsoo Chung. I'm currently an associate professor of medicine at Seoul National University College of Medicine in Seoul, Korea. As a co-corresponding author of this study with Professor Jung-Hoon Lee, I am very happy to introduce you our study entitled Deep Learning Model for Diagnosing Gastric Mucosal Lesion using Endoscopic Images. Endoscopic differential diagnosis of gastric mucosal lesions such as benign gastric ulcer, BGU, early gastric cancer, EGC, and advanced gastric cancer, AGC, are important. So our endoscopists must be trained with appropriate endoscopic techniques and have sufficient knowledge and experience. However, technical limitations remain, creating the possibility that pathologic lesions could be missed and misdiagnosis could be made. Consequently, the accuracy of endoscopic diagnosis has been reported to be positively associated with the endoscopist experience. Recently, the advances in artificial intelligence (AI) technology have been applied to GI endoscopy field. In this study, we aim to develop and validate a convolutional neural network (CNN) based endoscopic diagnostic model consisting of three consecutive submodels. First, lesion detection model (AILD) for detecting gastric mucosal lesions. Second, differential diagnosis model AIDDX for providing differential diagnosis for gastric mucosal lesions with BGU, EGC, and AGC. And third, invasion depth model AIID for estimating invasion depths in EGC. We also compared the performance of AIDDX and AIID models with those of endoscopists and EUS. Our study included 1,366 consecutive patients with gastric mucosal lesions from 2 referral centers in Korea. In total, 160 BGU, 843 EGC, and 363 AGCs. Histologic diagnoses were set as the criterion standard. Among the multiple endoscopic images, a single representative image was manually selected from each patient for model development and validation. For the ground truth data regarding lesion detection, lesions were manually drawn on the obtained endoscopic images as binary lesions of interest, marked by 2 expert endoscopists with more than 5 years of endoscopy. To quantitatively evaluate the performance of the AILD model, we compared the manually marked ground truth ROI with the automated segmentation performed using the AILD model. For the quantitative evaluation of the AIDDX and AIID model, we calculate AUROC accuracy, sensitivity, and specificity of each model for both internal and external validation sets. Next, we compared the performance of the AIDDX model and endoscopists in the internal and external validation sets. 19 differently experienced endoscopists, 5 novices, 10 intermediates, 4 experts reviewed endoscopic images. These images were identical to those used in developing the AIDDX model. The endoscopists were given a 5-scale checklist, which they used to score lesion and predict diagnosis. In addition, for EGC, we evaluate the AUROC accuracy, sensitivity, and specificity of the EUS result for prediction of invasion depths. These results were compared with the performance of the AIID model, and the statistical analysis were performed to evaluate the significance of the internal and external validation sets. Here are the results. For differential diagnosis of gastric mucosal lesion, the AIDDX model showed a good diagnostic performance for both internal and external validation sets, AUROC of 0.86. This performance was comparable with that of experts, AUROC of 0.89 in the external validation set, and was significantly better than that of novices and intermediate endoscopists. For evaluation of depths of invasion in EGC, the AIID model showed a fair performance in both internal and external validation sets, AUROC of 0.78 and 0.73 respectively, which were significantly higher than EUS results performed by experts. In this study, we developed and validated a novel deep learning-based AI model for endoscopic diagnosis of gastric lesions at 2 referral centers in Korea. This AI model could detect and differentiate the lesions better than intermediate-level endoscopists with less than 3 years of experience. Also, our AI model estimated the invasion depth of EGC better than EUS when sequential algorithms were applied. This result suggested that this multi-staged consecutive AI model can support endoscopists who have less than 3 years of experience or who are not familiar with EUS. It can also be used as an educational resource in countries where the prevalence of gastric cancer is relatively low. In addition, this model could play a role as a companion technology for many endoscopists regardless of their experience level, so that it could relieve operator anxiety and lessen the decision-making burden. We hope that this study will be helpful researchers who are interested in the application of AI in the field of GI endoscopy, and also hope that it will serve as an opportunity to consider how AI can change and improve our patient care in the future. I would welcome your comments and feedback that may you have. Thank you very much.